Thank you to APACC for this opportunity. Today, I will share our modeling study on the long-term impact of long-acting injectable PrEP, cabotegravir, which we also call CAP, among men who have sex with men in China. This is our team. We have no conflicts of interest and sincerely thank all collaborators, data contributors, and funders for their support. In China, sexual transmission accounts for 25.2% of new HIV cases in 2024, disproportionately affecting MSM. Oral PrEP is effective but adherence-dependent. CAP, approved and commercialization in January 2025 in China, offer 96% efficiency and reduces adherence burden, making it a promising alternative. We developed a compartment model in simulating HIV transmission among 5 million MSM aged 15 to 64 in China. The population is split into 80% low-risk and 20% high-risk groups based on the number of sexual partners. We evaluated turn intervention scenarios targeting high-risk MSM over 20 years, that is 2024 to 2043. I'm sorry, maybe I just, how can I go the previous?
The previous one?
Yes, sorry.
Okay. Just this button over here.
Oh, okay, thank you. Sorry. Yeah. And parameters came from a national MSM survey of 1,545 participants across 20 cities. Although only 7.1% perceived themselves at high risk, but 68.3% made PrEP candidacy criteria according to the 2023 Chinese expert consensus. Among eligible MSM, 72.5% were willing to use daily oral PrEP, and 49.3% were open to CAP. And we constructed 10 intervention scenarios based on 3 PrEP modalities, that is, daily oral PrEP only, CAP only, and their combination. For each modality, we consider different coverage levels among high-risk MSM based on our national survey data on currently use and willingness to use PrEP. And our model included demographic data, transmission probabilities, disease progression, and intervention parameters from published studies, official data, and our national survey. And our model, the outcomes included HIV prevalence, HIV incidence, and cumulative new infections of HIV, and percentage infections prevented. We also assessed time to HIV elimination, defined as incidence below 0.1 per 100 person years. And we collaborated our model against the prevalence, and our model fits the historical HIV prevalence trends well. The figure on the left shows the estimated HIV prevalence among all MSM included in the model. In all scenarios, we can see a decrease in HIV prevalence. And for the incidence projections, we also observed it consists advantage for PrEP. By 2043, daily oral PrEP could reduce incidence from 0.46 to 0.17 per 100 person years in scenario 2, while CAP could lower it further to 0.11 in scenario 6. In the figure on the right, the right line with circle represents daily oral prep at 100% coverage among high-risk MSM, and while the right line with asterisks represents CAP. As you can see, CAP demonstrates greater effectiveness in reducing incidence. This figure is about the national model for all MSM, and these slides will break the results down by risk groups. The left figure shows the incidence results for the high-risk group MSM, and the right figure is about low-risk MSM. These two pictures have different access skills, and we can see that most of the impact is especially from CAP and is driven by high-risk MSM, with some indirect benefits to the low-risk group. Therefore, we think that targeting CAP to high-risk MSM can help achieve broader population-level impact. And in our sensitivity analysis, we examined what happened if adherence to daily oral prep were improved. As expected, this narrows the gap in effectiveness. However, even at the same level of coverage and improved adherence, CAP still prevents more infections. And we also tested a worst-case scenario, assuming all PrEP users stop using condoms. This led to a 35 to 40% decrease in effectiveness for daily oral PrEP. However, CAP remained effective with only a modest reduction, that is less than 2% reduction, in infections prevented. This suggests that CAP is more robust even in the face of behavioral changes. Although HIV elimination remains a long-term goal, our results show that higher PrEP coverage could bring this goal closer by 13 to 20 years earlier. This table is sorted by the predicted year of elimination. In the red box, for example, you can see that with 100% CAP coverage among high-risk MSM, elimination could be achieved by 2043. In conclusion, our modeling was based on the total MSM population and includes analysis of those at low risk and high risk of HIV. CAP consistently outperformed daily oral PrEP, shortening the time to elimination and achieving greater reductions in incidence. Higher coverage levels accelerate these benefits, and achieving the 2030 elimination goal will require multiple approaches, including behavioral strategies with both oral and injectable PrEP. My name is Pengyue Guo, and thank you for your attention. I welcome your questions. Thank you.